Hello, everyone, and welcome to today's webinar, Policing as a Public Health Issue. My name is Donnie Zemmel, and I'm the project coordinator for the Region 5 Public Health Training Center. This webinar is offered in partnership with the Washtenaw County Health Department, the University of Michigan School of Public Health Practice, and the Michigan Institute for Clinical and Health Research. The Region 5 PHTC is part of the National Public Health Learning Network. With 9 other training centers across the country, we seek to strengthen the skills of the current and future public health workforce through continuing education and student development. We encourage you to check out our other offerings on our catalog at rvphtc.org. Now, a note on some housekeeping items. Today's webinar is being recorded and everyone is in a listen-only mode. Please enter any questions or comments that you may have using the chat box. We will not be using the Q&A or raised hand functions in this webinar. Depending on the question, we may type back an answer to you or save it for the end, and we will do our best to get to as many questions as possible. The slides were sent out in the reminder email earlier this afternoon, and the recording and slides will be available when the on-demand version is posted later this week. We'll email all those who registered when it's ready. There's no CE or certificate offered for this training. So we're excited to have 3 wonderful speakers with us today. To start out, we have Paul Fleming, Assistant Professor of Behavioral Health Education at the University of Michigan School of Public Health, who will bring some much needed historical context to this topic. Next, we'll have Jimena Loveluck, the Health Officer for the Washtenaw County Health Department, who will provide some information on the role of public health and where we are now. And lastly, we'll have Maria Thomas, the Advocacy Director of C.S. Mott Children's Hospital and Director of Community Benefit and Community Health Needs Assessment at Michigan Medicine, who will share some evidence-based strategies for moving forward. Now, here are our learning objectives, and these are the things that we'd like you all to come away with after the end of this webinar. But really, we'd like to just start out by saying that the point of this webinar is to move beyond the statement that policing is a public health issue. Many of us in the public health world have heard this statement over the past year, but we're really going to spend some time today to dissect what it really means and what we need to do in order to move forward. We recognize there is no way to cover everything in the 1 hour that we have today, but we do hope that this webinar will serve as either a starting point or a continuation for further discourse. Our discussion today will cover the historical context of policing and the connection to public health and health equity, but it's important to acknowledge that for many people, this is not purely an academic conversation, but a real experience of harm and trauma. We hope that by the end of this webinar, you'll have a better understanding of this systemic issue and strategies for police reform so that we all can collectively be better equipped to keep our communities safe and healthy. So without further delay, I would like to turn it over to our first segment with Paul Fleming.
Thank you so much, Donnie, and to all the organizers of this for this session. And I also want to thank all the attendees here. It's great to see so much interest in this issue. I want to start off by saying that much of what I and we talk about today is built on the foundation of activists and community members, particularly from communities of color, who have long taken a critical eye to our institutions of law enforcement and highlighted the issues related to health. I'm going to take us through a quick and incomplete history of policing in the US, and it's incomplete because there are so many histories and aspects that I will not have time to cover. I also want to acknowledge that activists in Detroit, Los Angeles, Ferguson, Minneapolis, and right here in Washtenaw County have lived this history and have raised up the harms of police violence since long before I was born. We are here today because of these activists and the legacy of all those whose lives have been cut short because of police violence. Before I get into the history, I first want to tell you where we are right now in terms of policing as a public health issue and why talking about history is so important. ample public health research has shown the harms of current police practices in 21st century America. In the simplest terms, the direct harm that is caused is that police kill over 1,000 people each year. And there's over 50,000 known injuries among young people each year. Simply put, these are public health issues because they involve issues of death and injury. But not only is it an issue of public health, it's also a health equity issue. These deaths and injuries are not distributed evenly across the population. We can see that 1 in 1,000 Black men and boys will be killed by the police in their lifetime. American Indians and Latinx men are also more likely. And of course, police violence doesn't just affect men, but it affects people of all genders. And these killings are not patterned just by race. They're also patterned by other markers of social status, such as immigration status, gender and sexual identity, poverty, mental health status, or other issues. And truthfully, the killings and injuries are somewhat at the tip of the icebergs in terms of health impacts. Police violence has spillover effects. So the hypervigilance that some communities need to practice because of fear of police violence causes lots of different mental health and physical health problems. We see that in many communities of color, for example, telomere length is shorter, which means that they have advanced aging, causing health issues. It also has impacts on family and community cohesion and breeds mistrust in not just police, but in government institutions, including our public health institutions. Next slide, please. So let's move into the history a little bit. And I want to first start with why are we talking about history? Why are we starting with history? And it's important to note that if we want to transform our world in the future, we need to have imagination. We need to understand that change is possible and imagine different futures. Americans in the early 19th century had to imagine a country without chattel slavery. Americans in the early 20th century had to imagine a world without Jim Crow and redlining. And those of us in the 21st century now, we need to imagine a different world that doesn't have these harms. The quote here on the slide says that studying history enables us to begin to notice possibilities. By studying history, we can see how the world we have now is one that was created, and it can be transformed like it has been transformed in the past. So we really want to imagine, what could public safety look like if we had made decisions differently in the past? And what are the different decisions we can make now? So when we think about the origins of policing and police, it's critical that we see that the origins are in policing socioeconomic inequality. During times of chattel slavery, police or slave patrols policed enslaved people to help protect the property of white landowners. As part of colonization processes, colonizers policed those who were colonized. In fact, the earliest police force was established by Britain to control and subjugate the Irish. Finally, policing grew in the wake of the Industrial Revolution as wealthy business owners sought to oppress the rights and liberties of the working class. Race and class have always been central to ideas of policing. And in the US context, that means that policing was formed for wealthy whites to police community of color and other poor whites. This is the origins of policing in our country. Next slide. Cities in the US didn't start to have police forces until the mid-19th century. That means that our current idea of policing in the US is less than 200 years old. Much of the efforts in the beginning were focused on policing Black Americans and immigrants. The Black codes were developed in the wake of the Civil War to criminalize Black behavior. Jim Crow also began sprouting up for police forces to enforce. Another focus was the control and subjugation of the growing number of immigrants who are arriving to the US in the late 19th century. Our modern version of policing was developed by August Bollner in the early 20th century. Next slide. He was a military veteran and took a very military approach to developing a police force in Berkeley, California, which was then the model for police forces across the country. He's a big part of the reason that right now in our police forces, we refer to captains and lieutenants and other militarized language. One thing that he said as he was developing this police force, which originated in Berkeley, California, was, "We're conducting a war against the enemies of society." Key here is that some of the foundations of modern policing is that the police force was set up as adversarial against its residents. Next slide. Of course, the racist policing from the 19th century continued into the 20th century. Black residents continued to be criminalized and were targeted with disproportionate patrolling, arrests, indictments, and guilty verdicts. This prompted many white social scientists and policymakers to conclude that Black people were more inclined to be criminal. And this, of course, just perpetuated the cycle of racist policing. Next slide. In the 1950s and 60s, white rage against civil rights gains prompted unrest in cities across the US. There were growing questions about how to address crime in the US. A 1967 commission initiated by President Johnson concluded that any effort to address crime should address social determinants of health. It said, money for schools is money against crime. Medical, psychiatric, and family counseling services are services against crime. The report scoffed at the idea that police and prisons could solve the issue of crime. Present-day calls to defund the police echo these conclusions, that we should be funding things that help people thrive as opposed to funding more state violence. Next slide. But if we fast forward to the next year, Congress and the Johnson administration passed a bill that shifted resources for addressing crime and social problems to the police. This was part of Johnson's war on crime and the precursor to the war on drugs. So now we enter the war on drugs era. There's ample evidence that points to the fact that the war on drugs was part of a strategy to continue racial oppression after the gains of the civil rights era. The book, The New Jim Crow, really details that example if you're interested in learning more. In this graph, we can see that the orange lines are crime rates and the purple line is state and local funding on police. Between 1970 and 2010, funding for police just keeps climbing, while crime rates peaked in the 80s and 90s. We can also look at this next graph. The blue line shows funding for public welfare programs like food stamps. Since 1970, funding for public welfare programs dropped somewhat, but the brown line shows that funding for police, prisons, and courts increased drastically into present day. So we can see by zooming out that the war on drugs era, we have prioritized policing as a solution to social problems rather than prioritizing social welfare programs. This has been called by some as organized abandonment, that we are no longer as a government supporting residents and citizens in need. Next slide. War on drugs policing is characterized by numerous aspects that makes it damaging to the health of communities. First, it has drastically increased the number of officers, and many of them are targeting street level drug offenses and ensnaring people with other minor offenses, wrapping them into the criminal system. It is characterized by stop and frisk practices and the use of SWAT teams, which can terrorize communities. It has increased, as I've shown, funding for police. It's expanded police powers, which has really eroded some of the privacy protections that are within our Constitution. And it has been shown to specifically target Black and brown communities in the US. It has also substantially militarized the police. This picture is a slide from the Department of Defense presentation to local police showing what kinds of military equipment they can ask for. The 1033 program is a program that transfers surplus military equipment to local police departments. And there's been over $7 billion worth of equipment transferred. Next slide. This familiar graph shows that since the initiation of the war on drugs in 1971 and its amplification in the 80s, incarceration has drastically expanded. And those racist policing practices translate into disproportionately Black and Latinx number of incarcerated individuals. As I mentioned,
Paul.
Thanks, Donnie. Next slide. As I mentioned, Black and Latinx individuals are often targeted with war on drugs policing, but they actually do not use drugs more than white Americans. They are targeted as part of police discretion. Police, often guided by policymakers at the local level, are choosing to patrol Black and Latinx neighborhoods. Next slide. They are choosing to target public housing instead of college dorms. And they are choosing to prioritize street drug sales instead of examples of corporate theft. Again, this speaks to choices of police at the institutional level and the choice of policymakers, not necessarily always just individual police. Finally, when we talk about policing, we're often thinking about city police departments, but other forms of policing like ICE have used similar tactics and have similar harms. I also want to highlight this book by Dr. William Lopez, Separated, which details some of the immigration policing here in Washtenaw County. Next slide. So we can see from what I've shared that policing has become increasingly violent over the years. And so these numbers representing the harms to public health is disturbing, but not surprising given our history. And as a society, we have chosen policing to solve social problems rather than choosing public health approaches. For those of you who are interested in learning a bit more about the evidence showing a link between policing practices and public health, I'd encourage you to visit the website of the Michigan chapter of Public Health Awakened, where you'll find resources to help understand this issue, as well as other links to journal articles and other things that help give more statistics. So now it's my honor to pass it over to Jimena Lovelock, who is our dedicated health officer at the Washtenaw County Health Department.
Thanks so much, Paul. And thanks again to the organizers of the event and for all of you who are attending today. So as the local health officer and the administrative director of a local health department, I wanted to talk a little bit about our authority as health officers, the authority of the health department, and the intersections with law enforcement policing as a local health department. So first of all, I just wanted to talk a little bit about the Michigan Public Health Code, because certainly much of our work, particularly in pandemic response, has been based on the authority that we have through the Michigan Public Health Code. And just wanted to share a little bit to give context excuse me, about the Public Health Code. In Michigan, the Public Health Code was established in 1978. It's considered one of the most comprehensive and contemporary codes in the nation. And it's an interesting sort of structure in Michigan, because really the Public Health Code allows local health departments really to act on behalf of the state health department and gives them parallel authority to the state health department. And so we obviously provide services in response to federal and state laws, administrative rules, needs identified through federal agencies, and of course, most importantly, local needs identified through our community health assessment process. Next slide, please. This is a description of the local health department's role in our Michigan Public Health Code. And I think that it's probably very standard description of what a local health department does and its role in preserving, protecting, and promoting public health. I do want to just say, in terms of our role in the Washtenaw County Health Department, we have very much focused our work for several of the past years now on promoting health equity. And we do that through a process of community engagement, really working with community partners and community members to address community identified health priorities through community-driven solutions. And in the health department, we developed guiding principles for health equity a couple of years ago. And of course, those are sort of sharing and stating that we are committed to working with community members and partners to address the factors that influence health, and particularly that we want to strengthen partnerships with community members that aid in community empowerment through community capacity building, organizing, and mobilizing. And also that we name racism and other isms as a barrier to health equity and social justice. Next slide, please. So certainly one of the most close intersections that we've seen between law enforcement and public health is often in response to an emergency or an epidemic, a public health emergency. And so as we look at the COVID-19 pandemic and the response that we have been undertaking for almost a year now, that local public health authority has resulted in several orders that have been provided in Washtenaw County. Obviously, our duty is to protect the health and address environmental hazards, control disease. As a local health officer, certainly not only issuing orders, but most importantly, taking actions that really protect health. And so these are just a couple of examples of local actions that have been taken through emergency orders. At the beginning of the pandemic, before we had statewide executive orders, we had local orders that were issued by myself and the local health department to protect essential workers through requiring screening at businesses where frontline essential workers were still working. We also established isolation and quarantine housing to ensure that people who either did not have a safe place to quarantine or isolate or were houseless had a safe place to do that. And then, of course, we are a university town, and we have several universities in our county. And so really thinking about how to protect the community at large as students returned to campus and limiting those outdoor gatherings. Those are just a few examples of local orders that we've taken and put in place over the time of this pandemic. Next slide, please. In addition, the other thing that we have found in Michigan after the Michigan Supreme Court challenged the authority of the governor and the ruling really resulting in her not being able to issue further executive orders, there was an even stronger reliance on the Michigan Public Health Code. And so as of that time, all of the orders that have been issued through the Michigan Department of Health and Human Services using that public health authority established in our Michigan Public Health Code. Next slide, please. So in addition to the Public Health Code being essential in giving local health departments the authority to issue local orders, I think the other aspect is the importance of always reviewing the public health code and addressing changes that need to be made. And I wanted to just kind of highlight the case related to HIV criminalization and stigma. So in my previous role as the director of an HIV service organization, we started work in 2016 to pilot the HIV stigma index in Metro Detroit. And this was done in partnership with several organizations. And what's unique about the HIV stigma index, which has been implemented in many countries around the world, is that the interviews are conducted and people are trained to carry out the work who are people themselves living with HIV. And so I just want to highlight some of the questions that we were able to talk about and get responses to in our Metro Detroit survey, which included almost 100 people living with HIV. And it shows really the lack of trust in our criminal system and really the impact that stigma has in accessing needed services. So when we asked how reasonable is it for a person who's otherwise feeling healthy to state that they don't want to get an HIV test out of fear of being prosecuted, if the test comes back positive, you can see that the majority felt that it was reasonable or somewhat reasonable for a person not to get tested. And so that's a huge barrier, and that we discovered that people were actually avoiding getting testing so that they would not have the responsibility of disclosing that information for fear of criminalization and prosecution. Next slide, please. So currently there are 32 states that have HIV-specific criminal laws and or sentence enhancements that are applicable to people living with HIV. The laws are varied in detail, but many are harsh in nature, and some have penalties, including incarceration, that are usually reserved for the most serious of crimes. Many of these laws are applicable whether or not actual harm has been demonstrated or caused. The US has initiated a plan to reduce HIV incidence by 90% over the next 10 years through the Ending the HIV Epidemic Initiative. But obviously, to succeed, we will need to not only overcome the scientific and programmatic barriers to testing, treatment, and prevention, but also to address the legal obstacles, racial discrimination, economic disadvantage, and homophobia that underpin many of the disparities that are prevalent in the HIV epidemic. These disparities mean that HIV criminalization laws disproportionately affect persons of color and lesbian, gay, bisexual, and transgender populations, potentially exacerbating discrimination. In Michigan, you'll see that we are one of 8 states to reform or appeal our HIV criminalization laws, and really to modernize the law as much as possible, taking into effect the advances in treatment and the science that we know exists around HIV treatment and viral load suppression. So in 2019, the then Michigan Governor Snyder signed 2 bills that revise sections of the Public Health Code and the Sentencing Guidelines chapter of the Code of Criminal Procedure. The changes created 3 tiers of the offense of felony sexual predation, established effective treatment or viral suppression as defenses to prosecution. Certainly this reform, there are still challenges. It does not go quite as far as we had hoped in terms of our advocacy efforts, but I think that's an example of how with some grassroots organizing efforts, people living with HIV, and leadership in our legislature, we also saw a change in our public health code to really try and modernize the HIV criminalization laws in Michigan. Next slide, please.
2-minute warning, Jimena.
Thank you. Many of you are familiar with the APHA policy statement on law enforcement as a public health issue. And I think the important aspect of this is really promoting a public health strategy that centers community safety and prevents law enforcement violence. Next slide, please. As a local health department, we have worked very closely with human impact partners and use a lot of their resources in helping to shape our work. And in the fall, they came out with a report that talks about how health departments can address police violence as a public health issue. And these are some of the elements that are included in those recommendations. And I just want to share that for us as a health department, we have worked very hard to develop partnerships with community members, with community organizers, really convening in various neighborhoods and areas of our county, not only those community partners, but other stakeholders, including members of our law enforcement, to talk about issues of police violence with community members. In addition, we have established a new Health for All website that really is a data repository, giving data accessibility to stakeholders in our county and sharing stories about action related to that data. And we certainly hope that we can add more data related to law enforcement and police violence as time goes on. And then finally, in terms of advancing policies and practices, I just want to highlight that in Washtenaw County, both our Board of Health and Board of Commissioners passed resolutions this past summer declaring racism as a public health crisis. And much of that work around addressing law enforcement and policing violence at the local level in our county and as a health department will be based on those resolutions and the action that will continue a community engaged approach to our public health work and looking at upstream change. Thank you. Next slide. And now it's my pleasure to introduce Maria Thomas, who will be talking about policing effects and reform.
Thank you so much, Jimena. And it was just so wonderful to listen to Paul and you set the stage for my section. So now that Paul's talked about the history of policing and Jimena has talked about the ways in which that history shows up today in who is criminalized and why, I'm so grateful that I get to spend this time with you today to invite you all to imagine different paths forward. So these are some graphics that I wanted to share from my friend and this incredible human being and organizer called Luna Nicole. And Luna lays out some scenarios. Say, for example, some folks are sleeping on benches in the park. Imagine that instead of calling for a carceral response, a city employee comes by, checks in to see if they need a place to sleep, food, water, or healthcare, and an hour later, those who want a different place have one. Isn't that public safety? Next slide. Or perhaps you're in a situation where you realize that your brake lights aren't working. Imagine if a city employee signals for you to pull over and says, hey, how about I replace those lights? And an hour later, the lights work, you're at home, no one's harmed, everyone's safe. Isn't that public safety? Next slide. Or perhaps you are in a really difficult situation where you are experiencing intimate partner violence. Imagine having the option to text a number and a trauma-informed crisis intervention specialist meets you in a safe place. And you are able to create a safety plan that will keep you safe in the long term. Isn't that public safety? Imagine having those options, especially for marginalized femmes, women of color, and trans and non-binary folks who very rarely call for that option to the police because they fear what that site of response, what additional violence that may bring. So this, and I'd love for you to take some time to sit with these images and these prompts to think more deeply about what could be. Next slide. Unfortunately, the current situation and the current system is not one where we have all of those things in place uniformly across communities. Unfortunately, right now, with the carceral state and the prison industrial complex being what it is, policing in prisons, instead of addressing social problems, are locking up those who are contending under the weight of them, right? This is this Angela Davis quote that really resonates. Prisons don't disappear social problems, they disappear human beings. So those problems are left untouched, and we're not addressing homelessness, unemployment, and drug addiction by relegating the human beings contending with those problems to cages. Next slide. So what do the public health experts say? This is a public health presentation. We're talking about policing as a public health issue. The APHA, which is the American Public Health Association, unequivocally states in their statement on advancing public health interventions to address the harms of the carceral system, they unequivocally recommend moving towards the abolition of carceral systems. By decarceration, by divesting from carceral systems and investing in the social determinants of health, and by committing to non-carceral measures for accountability, safety, and well-being. They recommend re-enfranchisement. They recommend funding research to evaluate the policy determinants of exposure to the carceral system and evaluating also alternatives. Next slide. So I'm actually going to take a little time to break down that APHA statement to a few takeaways that I hope you will carry with you. And public health takeaway number one is that a true public health approach is abolitionist. It focuses on root causes and the social determinants of health. So that means decarceration. That means a moratorium on building new cages, which are not conducive to anyone's mental health and do not keep us safe or prevent harms from happening. And it is an approach that divests from state violence and invests in the social determinants of health, like housing, like material needs, and the conditions where people live, work, play, and pray. Public health takeaway number 2 is that violence cannot remedy violence. The carceral state and the prison industrial complex are a relentless source of violence. And so that's why in that statement, you have public health and the APHA urging us to commit to non-carceral measures for accountability, safety, and well-being. Violence cannot remedy violence. In the next slide, you'll see that in our conception of violence, we need to include police violence in our understanding of the violence we are seeking to interrupt and prevent. And that's been a gap, I think, in some of the public health approaches. There are some good questions, and I hope we'll get time to get to those. And those are completely valid questions. So violence cannot remedy violence, and that includes the violence of policing. It includes the violence of prisons as well. We know that solitary confinement is categorized by the World Health Organization, by all the human rights organizations as torture, right? And so what criminal punishment and prisons do is they just relocate that violence without addressing the root causes or the sources of that violence. And that is not a public health oriented approach. And then the next public health takeaway is that we have to move away from this individualized, this hyper individualized framing and look at structural issues. And so the focus, as we all know, for public health is on preventing harm and preventing and reducing its incidence at the population level, right? Not just looking downstream, but looking upstream. Next slide. So what does that look like in terms of what does it look like to address structural issues? It looks like the APHA statement said, divesting from these institutions that don't address the structural issues and actually reinvesting and reallocating resources in those social determinants like affordable housing, like education, mental health counseling, and substance use treatment. That is what that structural analysis and intervention would look like. The next slide. And even those who completely support the police agree that cops are being asked to solve too many of our problems. Former Dallas Police Chief David Brown himself said, "We are asking cops to do too much in this country. Every societal failure, we put it off on the cops to solve. Not enough mental health funding, let the cops handle it. Here in Dallas, we got a loose dog problem. Let's have the cops chase loose dogs. Schools fail. Let's give it to the cops." And that is just too much to ask. Policing was never meant to solve all of those problems. Next slide. Actually, skip ahead to the next one. Now, I understand for those perhaps new to this concept of divesting from carceral systems and moving towards other systems, there's a lot of new information to process. And I just want to say it isn't just public health practitioners and survivors who are calling for these community-based approaches to preventing harm and true safety, accountability, and transformation. It is also anti-violence, anti-gender-based violence organizations or organizations that work with and are represented by sexual assault and domestic violence survivors. If we go to the next slide, we can see that anti-violence organizations themselves are inviting all of us to invest in these community-based safety strategies and divest from, as Jimena mentioned, criminalization, which only perpetuates cycles of harm, and to move towards true accountability and transformation. And so, in fact, the next slide talks about a letter that was signed by 45 state domestic violence and sexual assault coalitions last year, which acknowledged that this is a moment of reckoning. And particularly white leadership within this movement has repeatedly failed BIPOC or Black, Indigenous, people of color, survivors, leaders, organizations, and movement. In that letter, you'll see those bullet points. You'll notice how they echo so closely the public health APHA statement, you'll notice how these same ideas are reaffirmed. This idea of reforming the idea of public safety. Think back to those graphics about imagining. They unequivocally voiced their support to remove police from schools, to decriminalize survival, and to provide safe housing for everyone and invest in care, not cops. Again, that is the social determinants of approach. Social determinants of health approach, sorry. And I think, yeah, so that's a little preamble to the models that do work, these community-based strategies that I'll be getting into a little bit more. So if you go to the next slide. Before I talk about mental health and crisis responses and alternatives to truly transformative alternatives to the system that we have right now, and before I talk about violence prevention and other community-based strategies, I want to sound a note of caution and warning as we're thinking about how do we reduce police violence and how do we treat this as a public health issue. And that warning is that procedural reformist reforms do not work. Oftentimes, extremely well-intentioned people in public health ask questions about, well, what about body cameras? What about civilian review boards? How about implicit bias training and community policing initiatives? Unfortunately, the research is very clear that although these reforms are well-intentioned in nature, they don't get to the root of the issue. And oftentimes they consume a tremendous amount of resources, but don't deliver the justice that one would want. So that is why, for example, when you think about body cameras, we have reams and reams of video footage, but that was not enough to get justice for, say their names, Philando Castile, Samuel DuBose, Walter Scott, Tamir Rice, Sandra Bland, and so many other countless victims of police violence. Now to move on to imagining and building out these alternatives. These examples, and there are so many more, are pulled from the Barnard Center for Research in Women and their Interrupting Criminalization project that produces tremendous work in partnership with a lot of community-based organizations. And it's called the What's Next report. And I'm going to outline some categories of things that do work. So when we look at the category of alternatives to 911 calls and mental health response, there are tried and true tested programs that are community-based that are mobile crisis intervention teams. So things like Cahoots in Eugene, Oregon, or Parachute in New York City, or the Fireweed Collective. They offer responses that are decoupled from police departments. And they have proven to be very successful. And the thing is, this isn't far-fetched. Other countries have this kind of crisis intervention team with crisis workers and medical folk, right, that don't rely on policing. In the UK, for example, you can call a 111 number, which is separate from their emergency policing response 999 number. And then they can dispatch an ambulance nurse and mental health worker to the caller if needed. So not only is modern day policing a fairly recent intervention, Paul mentioned how in its current iteration, it's only about over 100 years old, right? This system that we have in the United States is not universal. There are other ways of doing this that would decrease the likelihood of being at the receiving end of violence in these kinds of mental health situations. The next slide talks about violence intervention and prevention programs. And there are so many excellent programs, and there's more that you can read in the What's Next report in detail, but there's Spirit House, API Chaya, which is Asian and Pacific Islander Chaya, Oakland Power Project, Safe Outside the System. And what's interesting is all of these are especially created and furthered by organizers who are from marginalized communities, and their focus is on people of color, on LGBTQ communities, and those whom policing does not sort of respond to or protect in the ways that that popular imagination seems to think that it does. One of my favorite examples is Mothers Against Senseless Killings, MASK, which is a group of mothers in Chicago who have reclaimed their block. And so this is them living out the idea of we keep us safe. Mothers are on the block every evening, barbecuing, feeding residents, and building relationships with young people. And so there are all kinds, you think about ceasefire, there are a slew of programs that do focus on violence intervention and prevention that work outside of policing. The next slide. And then we have responses that adjudicate and address harms that don't rely on retributive justice. So we're talking about models like restorative justice and transformative justice. And these are just some resources and organizations that take that approach. So there's the Creative Interventions Toolkit, which is a tremendous resource. There's the PODS mapping worksheet from the Bay Area Transformative Justice Collective, and there's Beyond Survival, which is a book which details and chronicles strategies and stories from the transformative justice movement. Common Justice is a New York City-based organization that uses restorative justice approaches. And on the next slide, we have information on Impact Justice's Restorative Justice Project. And if you go to the website transformharm.org, there's a ton of additional resources. And there's also a link at the bottom of that slide about the What's Next project, from which I draw many of these examples. Next slide. So as we're talking about charting ways forward, one note of caution is that we should not be replacing current harmful systems with other harmful systems. And so, from a public health oriented approach, we want to be looking at non-coercive harm reduction type approaches, right? And we also, I think in the discourse, have to be really mindful of resisting these binaries and labels such as worthy, unworthy, violent, nonviolent, innocent, criminal, because there's a difference between harm and crime. Crime is a socially constructed category that has a long racist history, as Paul outlined in his section. And so I think as public health practitioners, we have to affirm that mantra that no one is disposable. No one enters violence for the first time through committing it. Everyone is capable of doing harm. Everyone is capable of being at the receiving end of harm. And because of what we know about adverse childhood events and what we know about intergenerational trauma, a public health approach would be to really lift up this idea that no one is disposable and we cannot use harm to remedy harm. And I think I'll end with the last slide, I think, which is a quote about when we talk about defunding the police, what we're saying is we want more care laborers, not punishment officers. We're not saying create a new category of unemployed people. We are saying, let us transform the way in which we relate to each other and the ways in which we keep each other safe. And with that, I'll end. I have a list of resources also. These are some definitions, but on the next slide, there's resources, but I think I'm going to hand it over to Danny to facilitate the Q&A. Of all of these resources, and I encourage you to take a look at all of them, I'd especially like to point to Mariam Kaba's 9 solidarity commitments for 2021, because that's a practical way to get involved and engaged in this work of creating a better, more humane way of being in community. Thank you.
Thank you, Maria.
For listening.
Thank you, Maria, and thank you to all of our presenters. So a lot of really great questions have been coming in through the chat box, and we've been noting them. We'll do our best to get to as many as we can. So I'd like to ask if our speakers will be able to turn their videos back on. Jimena had to hop off for a moment, but she'll be back shortly. So to kick things off, one question that kind of came in a variety of forms was about putting theory into practice. How can, at an organizational level, how can someone get involved with supporting this transformation locally? And I think along with that, where does one begin when they're facing resistance? So I'll open that up to all of our panelists.
I'll take a stab at it. I think there are many entry points, and I think it also depends on your social location and whether you're part of a health department or a university, whether you're approaching this as a community member, a social worker, a public health worker. Jimena had a great slide about how health departments can address this issue. I think that's a very good one, especially if you're a health department employee. It was a list of recommendations from human impact partners. I think for just the layperson wanting to get involved, finding other organizations that are involved in this work and liaising with them is a fruitful approach, right? Organizing together is a way to perhaps knock down some of the institutional barriers you may be facing within your own organization. But I'm sure Jimena and Paul have some ideas as well.
Yeah, I just want to, I guess, echo what Maria said, that one of the ways is to get involved with organizations, which I think Maria has detailed a lot of lists. Yeah, and I guess I'm losing my train of thought right now, so apologies. But yeah, Jimena, I don't know if you have anything to add.
Well, just going back to what Maria mentioned in terms of some of the recommendations from human impact partners, I think really important to build those relationships with community organizers and community members. I think that's one aspect that we certainly have done a lot of work in developing those long-term trusted relationships. And I think also, again, speaking from the perspective of a health department, really, the role that we often play as convener, right? And really thinking about how we can bring, various stakeholders together and really do some work together to address the issue from both a community perspective as well as including law enforcement and other stakeholders in public health and activism.
Thank you all for that input. Kind of going along some of the responses that you've already provided, how can we apply the data that's already out there about, why we should be moving towards abolition? How can we apply that in institutions that are very slow moving? And how can we do that in a way to make sure that we're protecting folks along the way?
Paul, go for it. You've unmuted yourself.
I'll just say that I think, one of the keys here is knowing your local context and starting with a foundation of relationships. So building trust and relationships across your local context will let you know what gains are possible. So I think many of you have reflected in questions, well, how do we make these changes kind of right now? But this is something to think about as a long-term vision, right? And there's certain things that are going to be possible this month, this year. There's other things that are going to be possible within 5 years. And we never really know the pace of change. Things can change quickly in terms of public opinion or other socio-political events. So by building those relationships, keeping this topic at the forefront, education, we can take those steps as they become available and as those opportunities arise.
I think as public health people, we can also add our voice to what movements are trying to organize around, right? We can help with research that would aid the goals of what organizers are trying to make real. And I think the local organizing It depends on the sites that you have access to. I know there are a lot of public health practitioners who see the harms of what having cops on campuses can do. And there are movements led by faculty and staff and students, right? And community organizers to acknowledge that campus police grew out of a history of wanting to repress agitation and organizing around civil rights, anti-war, right? That was the genesis of campus police. And so this idea of the euphemism of school resource officers or cops in schools, these are not things that necessarily exist in other countries. And this is not, I think, again, I love, Paul, your imagination slide. I think we need to be thinking about other ways to manage challenging behavior in campuses, on schools that are more public health oriented, right? So you know, on a personal level, I think what that long trajectory and the movement towards the futures we yearn for will necessitate is also questioning how in our own personal lives we manage harm and address conflict, right? In parenting, how do we do it? Is it punishment-based? Is it timeouts? What are the ways in which we are prefiguring and modeling in our own relationships the kinds of non-punitive, non-carceral approaches, right? There's a reason why there's a school-to-prison pipeline. There's a reason why social service agencies sometimes can be the grounds for funneling entire marginalized populations to these carceral systems. So I'm thinking specifically of the history of child welfare and child protection services, right? And how that is weaponized against certain communities, and how instead of separating children from families that are struggling, offering families who are struggling the resources would be a public health oriented approach. So those are just some examples, but there are, I think, many ways to enter that conversation.
Thank you, Maria. I wish we had hours and hours to be able to get through all these questions, so it's going to be hard to select the next couple of ones. I guess this can be for everyone. What would you suggest is a public health response to offenses that are violent? They've been thoroughly investigated and deemed violent offenses, especially in the interim as we are transitioning to these new sorts of approaches.
So I think the question about, and actually the slides about domestic violence that I have in the presentation address this somewhat. And there are a lot of other resources on the Barnard Center for Research on Women's site and the Interrupting Criminalization site, is that the current system of policing doesn't necessarily address those issues of violent crime and the sources of it, right? It doesn't necessarily address the issues of domestic violence, and it doesn't especially center the needs of survivors, especially if they are people of color, right? Or have other issues that make them, or status, immigration status that make them reluctant to call the police because they're afraid of further violence being enacted, or they're afraid of losing their home, or having their children taken away from them, right? It doesn't get at the root cause of issues. And so again, looking at that What Next report of how violence is addressed is, I think, is what we need to sit with. The other thing is, and this goes back to the violence cannot remedy violence. If you just kind of lock someone up, you are not addressing the root causes of violence. So I'd urge you to look at the work of organizations like Restorative Justice, like Impact Justice, like Generation 5, that addresses the reasons for violence may happen in the first place, right? There's a difference between retributive justice and restorative justice. I think the punitive system asks the question of, well, who can we punish, right? But does it prevent harm from happening? No, it does not, right? what restorative justice, for example, the set of questions it asks is, how can you be kept safe, right? What are the conditions that you will need in your life to be kept safe? How can justice be restored? How can harm be repaired? How can amends be made? And those are the kinds of things that break the cycles of perpetual harm. Because when you snatch someone from their community, you're rupturing kinship bonds, right? That there are long-term effects for trying to use violent approaches to addressing violence. Which is not to say that we are abandoning the community to harms. We know harms will happen. We are just envisioning other ways to build our community's capacity to deal with harm in the long run. And obviously, these changes are not going to happen overnight. So this is it's a horizon towards this work that we're talking about.
Thank you, Maria. So we are at time.
There are resources on this, and I'm sure Dani will share those. Those are valid questions, and people have grappled deeply with those questions.
Thank you. So we are at time. I do want to quickly wrap up by asking each of our speakers to, maybe in a word or in a short phrase, what comes to mind as you're imagining us moving forward, policing with a public health and health equity approach. What are some things that come to mind as we move forward? A word or a phrase? For me, I think of partnership.
Partnership is great. I would say also let's reverse the disinvestment in public health that's been going on in our country for years and years now.
Yeah, I would say kind of humanity, and I think so much of our conversation dehumanizes people who maybe have committed a crime or who are in jail. And so if we view everyone as human, then we might hopefully make different choices in our society.
I would say community, compassion, and healing.
Well, thank you all so much for all of the information, all of your insight that you've provided with us today. Thank you to all of our attendees who attended and asked wonderful questions. We will be preparing the on-demand version of this webinar in the coming days, so be on the lookout for an email with that information, and feel free to reach out to us should you have any other questions. We hope that this is just the beginning of the discussion, and hope that you all stay safe and healthy out there. Thank you.